So I'm Fiona. I'm a salaried GP at Hawthorne Medical Centre. I don't have any other qualification for that to speak other than that. I have had a career that is more, I would say, patchwork than portfolio. Have you got my photographs? Yes, here we go. How do I work this? This one? No. There we go. So I've lots of lived experience in terms of refugee health. I've lived abroad. Sorry, I've gone backwards, haven't I? All right, here we go. The building in the top left is the Horizon Centre in Salford, which existed, the building still exists, but the service existed between 2008 and 2014. So I have worked in a practice which was designed specifically to take care of asylum seekers in Salford. We had about 1,000 patients at the time. So I've done some work looking after asylum seekers in the NHS, but I've also spent time in the Middle East and North Africa. This is us, my husband and I were both mentoring Palestinian doctors in a Palestinian refugee camp. And then working up near the Syrian border, running clinics in Bedouin tents for people who'd just skipped over the border at the time of the beginning of the Syrian conflict. Again, in Jordan, working in a church, doing fruit and veg programs, but also doing home-based medical clinics as part of that work. And then this is us more recently. So about 3 months ago, Laura had a call from Migrant Health saying, would we as a practice be prepared to offer some stopgap intervention in a local hotel for 2 weeks on the edge of our practice area. And so obviously I was quite keen, it's my kind of area, but spoke to the rest of the team and they were also more than up for it. And this is a picture of us about a month ago doing diphtheria prophylaxis rollout. Didn't know there was such a thing required until about a week before we had to do it. So just want to say all of what we've done, I want to give credit to the absolutely brilliant Hawthorne team who have been ever so compassionate and also very sensible, finding a way to do things which, you know, we've basically been having to wing it and make it up as we go along. So I'm just wanting to share some of the learning from that journey that I guess really we've just embarked on. But before I do that, obviously this is a huge hot topic. It's never out of the headlines. Bit of a political football at the minute, and things have been changing like rapidly in recent years. COVID had a big impact on what was happening in the asylum-seeking world. So decision-making ground to a halt, travel obviously stopped. In all the other countries where the UN are working, resettlement kind of ground to a halt as well. So resettlement is where the UN work with refugees in established settings like Jordan, like Turkey, and look on the basis of their need about resettling them to countries in Europe and Canada and wherever else is open to accepting them. So all of that ground to a halt. Family reunions also started to slow down. And then in August 2021, we had the outbreak of war in Afghanistan and we had a huge evacuation. Maybe not huge enough, but it was huge. And at that point, we started to see hotels being used more and more to accommodate newly arrived asylum seekers, or at that point, they were settled migrants. There were 24,000 people accommodated in hotels in the country. 8,000 of them are still in hotels, and half of those are children. So that's a huge impact, and we're coming on to 2 years. In the current climate, we're still seeing resettlement going down. This is slightly out of date, end of last year, and family reunion reducing. But we are still seeing the total numbers going up. And why is that? Well, superimposed on what's happening on the kind of old traditional routes, we've got a sharp rise in people arriving in the country in small boats. So this started around 2018, had been happening in the Med from about 2014. And why are we seeing more of this? Well, there were fewer safe established routes for people. There's an increased opportunity because there are more organised gangs that are facilitating these journeys, but there's also a huge push factor. So people in places like Jordan, Turkey, they're feeling stuck. The war in Syria has been going on for 10 years now. Their families have been spread across the world. There's something in them that's lost confidence that they're going to be resettled on any other programme, and their extended family is all over the place. So friends of mine who are working in Jordan and Lebanon are saying, well, you know, people are losing hope and wanting to try other means. And if you've survived war and you've lost so much already, well, there's every reason why you might take a punt and try and come on a small boat and make a better life for yourself and your family when you're stuck. There's also new conflicts. We are only 11, 12 weeks into the conflict in Sudan. It's gone off the headlines, but it was terrible over the weekend. So there's all kinds of things happening. So we've got this, which has put pressure on accommodation. So now we've got, this is quite stark, isn't it? The number of people that are being housed in a way that we've never housed people before, mainly in the urban setting. So we've got 15 hotels in Greater Manchester being used currently, including 500 people housed in the city centre at the minute. Nationwide, 395 hotels being used, housing 51,000 plus people. And, you know, we've got housing issues in Manchester, we all know that, so where are these people going to move on to? There's a push to get the Afghan arrivals from almost 2 years ago out in the next 3 months, but where to, you know? So the wider picture in the UK, application numbers are still picking up, but we've also got this huge backlog. The system's not working. It's very unwieldy. The quality of decision making in the Home Office is pretty poor. So 43% of asylum appeals last year were, this is the appeals that were allowed. So if you can imagine, you've had an initial decision, then you appeal it, and 43% of those appeals are then given leave to remain. So that does give you the sense that that initial decision is not very accurate if it's wrong 43% of the time. That's in the year up to March 2023. So where do we fit in Manchester in the picture? It's a little bit out of date, but you can see the northeast and the northwest, high numbers per 10,000 resident population. And if you map deprivation, as we've been talking about all day, on top of that, you can see that these policies, these practices put a lot of pressure on us in urban areas where we're already pretty stretched. But just at this point, I wanted to zoom out a bit because I think it's easy for us to become quite parochial in our thinking and to just think about us as a nation. There's a bigger picture, there's a global picture. International movement across the globe is at an unprecedented level for all kinds of reasons. We have a perception in the UK that we are generous and everyone comes here. It's not the case. In 2021, we averaged 9 per 10,000 people, but the EU average was 14. So in this area, we punch well below our weight, and you can see us right down here at the bottom of the table. And zoom out further, globally, the UN estimate at the end of 2022 that there were 108.4 million displaced people, many of them internally. But you know, even Europe, it's relatively small compared to what's happening in the Middle East and Turkey. Venezuelans filling up places in Colombia, that's not on our radar. Uganda welcoming people from South Sudan, DR Congo. So on a global scale, you know, what we're seeing is a very small part of a massive picture. So the question is then, what can we do as regular jobbing GPs with the people who are sat in front of us? So first thing I wanted to ask, what health implications are there for housing people in hotels? Anyone want to shout out what things we might need to be thinking about as we embark on our nutrition, yes. So nutrition is interesting. We've had a series of complaints about the food from various people in the practice. So I went and had a chat with one of the Circle guys in the hotel, who then pulled out a petition that the residents had written and about 70 or 80 of them had signed, asking for, you know, food that was a little bit more seasoned according to their tastes. And, you know, bland British food, well, it's not going to be very appetizing. If you're used to kebab and, you know, all kinds of Middle Eastern delicacies. And meal times are very strict. If you don't make it to the hall for breakfast by 9:30, you don't get anything. So there are some things that we're talking with the hotel about that and how we can address that. The Circle guys who are overseeing the hotel are working with the chefs, hopefully we'll see some changes. Any other thoughts on things that are important? So communicable diseases, I heard, yes, absolutely. Infection, there have been in the UK, in hotels, but also in holding centres, outbreaks of diphtheria, measles, scabies, all kinds of things. Scabies is huge. And so I've had to kind of brush up on that and look at how do I diagnose accurately, especially with skin of different colour. So that's a big issue. So handling that when you've got a hotel full to capacity with people sharing rooms. Diphtheria, that's to do with people with incomplete immunisations coming and then being. And I had to go and look up, well, how does that present clinically? Because I don't know I'd recognise it at all. But ulcers and membranes over like sore throats. So just having a wider differential for some of those things, but then also being proactive in talking about incomplete immunisations, doing diphtheria prophylaxis, which is treating with antibiotics all new arrivals into the hotel, and then scabies, looking out for it, seeing everyone with an itch and not telling them to come back next week, because we don't want 30 people with an itch in the same hotel. So just as think about that, a few words. So yeah, this is my kind of brainstorm so far. There's lots of things that we haven't thought about just yet. Lack of privacy as well. I mean, they're all sharing rooms, so that is difficult. You're going through a lot. If you're not sleeping, someone beside you snoring, you've had difficult news from home. It's very disempowering being there. There's a real lack of agency, and I am concerned. I mean, this is the summer. We're in the edge of Rusholme. There's the park. Life is quite good. How's it going to feel in December if people are still stuck? So, just a few words to think. Think of integration. So when we started, we didn't quite know what to do. We got this 2-week contract to go and just basically do a walk-in. I called it the walk-out centre in the hotel. And then we got asked to take on the contract, which everyone said yes to, so we've done. We were given a clinical room in the hotel, which wasn't really fit for purpose, no good internet, difficult to run because you need, as well as a doctor, you need admin support, you need all of this. So it was very unwieldy, and it kind of came to a head one afternoon when there were so many people who wanted to be seen, no admin support, and me kind of raising my voice in Arabic. And I felt, this isn't quite right. This isn't how we do things in Britain. So we've decided to move back into our practice, but to really work on improving access and helping with access. Now, we could just take the money from the contract, give everyone appointments, and then they'd all DNA and say, well, they didn't come, so we tried. That's no good either. That's no good for a hotel where there's communicable disease, and we need to think about how to keep people healthy, not just the people in the hotel, but the wider population. So what we've done, or what we're trying, is a kind of one-stop shop where we've blocked off our healthcare assistant, a practice nurse, and one of the doctors. And we have used one of our admin team to do a walking bus from the hotel. So she's gone to the hotel, gathered up a few people that speak the same language to come over and have a new patient healthcare check, an enhanced one that we've made a template for. Kath, our practice nurse, has been wonderful and really genned up on catch-up IMS, and then the doctors are dealing with any presenting problems. I think it's going to be really effective. We got 10 over last week and it was completely overwhelming, so we need to do it but slightly lower numbers. Knowing about entitlements, is there any kind of asylum seeker who's not entitled to primary care? No, there's no asylum seeker who's been in the system, is currently in the system, or has come to the end of the process who's not entitled to primary care. Everyone is entitled to primary care, emergency care, and secondary care where it's to do with diagnosing or treating infection. So there's no questions about any of that. They're entitled to be registered and have access to full primary care services. Managing expectations has also been interesting. Breaking the bad news that it's actually really hard to get your minor varicose veins done quickly ever in this country, and you might actually be better going back to Turkey. So that's just managing expectations as well. That can be difficult, but it's fine. One key thing has been just really developing our signposting and logistics. Things like entitlements, HC2 certificates, using the minor ailment scheme, finding out which local pharmacy has a minor ailment scheme, because I didn't know, And is it working? Is it functioning? I went to speak to the pharmacist just to check. For the first 6 months, people in the hotels don't get any money. So they've got no cash, meals provided, housing provided, but no cash in hand. After a while, apparently about 6 months, we'll find out, they start to get £9.10 per week, which doesn't go very far. So this is we would be prescribing all the things that you wouldn't normally prescribe in NHS. We're doing prescriptions for everything, but also using the minor ailment scheme, producing maps to find local services and helping with understanding letters. That's been really key. So I would recommend, what we've done is we've found a member of staff who's really up for learning and just gaining experience, and we're just helping her to be the first port of call between the hotel staff and the practice. Seems to be going well. Talked about infection. I find it quite helpful to think about pre-journey, during the journey, and after the journey. Pre-journey, so what things are endemic in the country that people have come from? TB, well, it's on the service spec that we were given to screen for TB. We didn't know what to do. We phoned the TB clinic who didn't know what to do either. So we came up with a plan. So we're screening with questions for active TB, any concerns, sending them to A&E. Any history of TB, latent TB, or significant exposure, we're sending to a screening clinic in the hospital. Then we're looking at incidence in the country of origin. So if they're above a certain incidence, we're sending them for a chest x-ray. We're in the hotel. We want to make sure we pick things up. The first afternoon I was there, had a young guy from Eritrea, bit of strange chest pain, weight loss, and slightly tachycardic. And I was like, I can't keep him in a hotel without knowing that he doesn't have TB. Didn't have an NHS number, I couldn't do any tests, so just sent him to A&E. Lo and behold, Jay had pleural TB, so he's not getting treatment and being looked after well. So just having those things in your mind. HIV, we're screening everyone for HIV and bloodborne viruses, not necessarily because, well, the HIV, that they're higher incidence elsewhere, but it's high in Manchester. So actually, the recommendations are that anyone joining any practice should be offered HIV screening. So that's how we're encouraging people to do that. Thinking as well about parasitic infections, full blood counts with high eosinophils. That's one thing to check. And then on the journey, we've always mentioned scabies already. A lot of people coming from the Middle East have come from Libya, come through Libya, where they've been often held in, it's like prison detention centres, loads of people crowded in a room. That's where a lot of our people have got scabies. Fungal infections, spending time in the sea, in boats. So we've been doing that kind of screening as well. The other thing just to mention as well, sexual health can be complicated to ask because it's culturally a very sensitive area, but what we're finding is if we just say, well, often on a journey like what you've been on, people for lack of resource end up in situations where they do things they wouldn't otherwise have done, or they could be at risk of sexual exploitation along the journey. That's been really helping us with encouraging sexual health screening. Quick slide on communication. Who amongst you has used an interpreter? Everybody? Who's had an interpreted consultation that hasn't gone well? Right, most of us. Who's ever had any training working with an interpreter? Nope, not many people, right? It is a skill. I've got some guidance on that it's worth reading and having a look. I'm happy to send it round, but just a few pointers. Think about, first of all, who's interpreting. There are people who shouldn't interpret for other people, particularly family members, the friend who shares a room in the hotel, all of these kind of things. So just think, who's interpreting? Is it appropriate? And sometimes you need to dig a little bit to check. If something's not working, just reflect that back. Just voice gently your concerns rather than being quiet and making do. Try to give the patient all the best of your non-verbal communication. So keep your eyes on them. Direct your words to them. Use a second person. Speak to you, not he. Face-to-face is best. And then the other thing I'd say is try to look after interpreters. If someone's listening to a history of trauma and they come from the same culture, they may have a story that makes us read. I mean, I come from Northern Ireland. There are times that listening to stories from Northern Ireland can be difficult because it just triggers, and I wasn't terribly affected. So just be mindful of who the interpreter is as a person, check in with them, look after them too. There we go. didn't click through those. And just in terms of communication, that whole culture of belief, bearing witness to what people have said, that's really powerful. Being believed is really powerful. That's not always the case when you're having an interview with the Home Office. You're often, the default is not to believe or to prove wrong or to look for inconsistencies. But we're in a different seat as healthcare professionals. Being believed can be very healing and powerful for people. So think compassion as well. So the service spec we got says screen for mental health problems. So far, we haven't been doing that in the hotel. Where our approach has been more of addressing things as they come up, addressing them as they present, giving space for things to present, but not necessarily going digging. Why? Well, we're in a hotel. Mental health services are struggling. The future's very uncertain. If I go digging and dig up a big, long story of trauma, what am I going to do with that? I could make the patient a whole lot worse, and it might not be helpful. So I'd caution wisdom, but also leaving space for things to come up. So what I call a trauma-informed approach. How does PTSD present? Well, it is often physically. Headaches, tummy pain, musculoskeletal pain, palpitations, shortness of breath. Make space. Are there any difficult memories, difficult experiences that you've been through that could be relevant? People often use the phrase, think too much. I think too much. Usually means their memories, maybe flashbacks, nightmares coming into their mind. So just when you hear those things, make space for people to talk about difficult experiences. I just want to encourage you that PTSD, it is a primary care diagnosis. When I started working with refugees, I thought that's a psychiatrist's job, that's not for me. I kind of upskilled myself on this. I got the DSM-5 criteria, stuck it on my wall where the patient couldn't really see it. But you know the mental checklist we have for depression, you can do PTSD in the same way. And because the treatment, the second line is mirtazapine, we're on safe grounds in terms of prescribing. So if you feel it, you can make a diagnosis, you can use the criteria. Don't be afraid to prescribe. That can be really helpful, especially when there's not much in the way of the first line interventions, which are CBT and EMDR. Those are going to be hard to access. So just to finish off, on Saturday, 2 months or so after arrival, our hotel entered a team into the Refugee World Cup, which was held in Whalley Range, didn't you know? So the Refugee World Cup, part of Refugee Week, we managed to sponsor these guys. We happened to have 2 Iranian football coaches sharing a room in our hotel. So that was fantastic. They got the team together, got them trained. Didn't go brilliantly on the football front, but it went really well in terms of just connection. The reason I put the Arabic word up, the Arabic word is ajanib, which is the word for foreigners in Arabic. Now, Arabic is when we hear the word foreigners, we think of outsiders, right? People who've come from outside, outsiders. The Arabic's a beautiful language. All the words come from like 3 or 4 letter roots. So the root for ajanib is jinb, jim, it's basically J and B in Arabic, but it's Arabic for beside, so it's the word for beside or alongside. So in Arabic, the word for foreigners really means alongsiders or besiders, and I find that quite a helpful thought as I'm there as the doctor, as a healthcare professional in that setting. How do I be a good alongsider doctor? How do we be good alongside our healthcare professionals? To the hotel. This is our team out supporting them. So I've rattled through that. I'm happy to take some questions. It's obviously a big field. I'm also happy to take queries